Welcome to EmCyte's webinar series. Join us as we explore the latest clinical insights and the science behind precision biologics.
Advancing musculoskeletal healing with protein-rich PRP. And tonight we will hear both a clinical and a scientific perspective. My name is Natalie Stevens. I'm the Scientific Director of Biophil Scientific Research. Biophil is a contract research lab. We specialize in providing testing services and support to both biotech and medical device companies. And our wheelhouse or expertise lies in testing concentrating devices that generate platelet concentrates and stem cell concentrates. So we've been around for over 2 decades, actually, and we've worked with most of the concentrated devices that are on the market today. We've been a significant part of EmCyte's research program for almost 2 decades, and during this time, EmCyte has continued to innovate and evolve and to deliver a wide range of top-tier biologics. So usually I'm behind the scenes in the lab, but I'm really glad to be here to step away from the bench and get a little closer to the clinical realm. And it's exciting to hear more about the application of devices and the biologics that we're usually testing and analyzing. Now, so EmCyte, as you know, is hugely committed to education on biologics. There are workshops, training sessions, training videos, conferences, you name it. And this webinar series is another element to that commitment to share knowledge on regenerative therapies. And the goal of the series is to advance regenerative therapeutics by uniting clinical expertise and scientific innovation. The idea is to deliver research-based evidence and insights that enhance biologic understanding so that you, the clinicians, can achieve procedural precision and most importantly, improve patient outcomes. As we know, PRP has evolved. It's not just a simple platelet concentrate. Plasma proteins matter, immune cell profiles matter, and monocytes in particular are gaining attention for their role in immune modulation. And when we pair that with concentrated A2M, we're providing a more targeted regenerative strategy. So today we'll explore two clinical applications of EmCyte's protein-rich PRP, and that's generated using the Pure PRP super physiologic device, as well as the core ultrafiltration device. We'll have two presentations, one by Dr. Eric Latzka, and the other by Dr. Sina Farzaneh. We'll then follow up with a Q&A segment and then a very brief announcement at the end. So stick around for that. You don't want to miss that. And we'll also discuss some practical considerations for incorporating the biologics into your treatment workflows. So let's introduce our guest speaker for the night, Dr. Eric Latzka. He's dual board certified in physical medicine and rehabilitation in sports medicine. He did his residency at the University of Washington in Seattle, where he was also an award-winning educator, clinical assistant professor, and he directed the diagnostic ultrasound curriculum for their sports medicine fellowships. Dr. Latzka has served as a clinical expert for the Washington State Health Technology Assessment Program and a member of the AAPMR Biologics Curriculum Committee and the AAPMR Technical Expert Panel on Biologic Management of Osteoarthritis of the Knee. It's a mouthful. So he joins us tonight from Boston. He's a born New Englander, as you may have heard, Pats fan. Good luck against the Miami Dolphins next game. And without further delay, I'll hand over to you, Dr. Latzka.
Thanks, Dr. Stevens. You went deep into the CV there. Picked out the hardest things to say. Thanks for having me today. Let me just share my screen. Okay, so we're going to talk about a couple of clinical approaches that we've been using at my office, Boston Sports and Biologics, in regards to protein-rich PRP with A2M and monocyte-rich PRP using EmCyte's new devices. So first, my disclosure, I am on the clinical advisory board for EmCyte and have been since the summer. Dr. Stevens already introduced a little bit about my background, but I was happy to come back to Boston, join Walter Sussman at Boston Sports and Biologics, and I've been there now for about over 2 years. The two patients I'll be talking about today, the first is a 40-year-old male with chronic medial knee pain, so an active guy, hockey player. He is a combination of moderate medial tibiofemoral chondromalacia and a complex medial meniscal tear. He's treated this off and on for a long time, over 10 years, with different activity modifications, multiple corticosteroid injections, but no surgery, as he's never had mechanical symptoms and has been trying to avoid that. The second patient is a 60-year-old male, former collegiate football and semi-pro football player who's had chronic insertional Achilles tendinopathy for decades. He's treated with just about everything conservative, including shockwave therapy, multiple rounds of physical therapy. And then when I first saw him, we ended up doing a Haglund debridement with the ultrasonic 10x bone device. And he had a good deal of improvement after that, but he still had some lingering pain, especially when he tries to return to weightlifting. So he's looking for something else aside from surgery. So first we'll start with patient number 1 and knee osteoarthritis. And this is the usual treatment spectrum that I'm discussing with my patients and what their options are for these degenerative meniscal tears. His may have started acutely, but now it's in the presence of arthritis, and we can call it, and it's chronic, so we can call it a degenerative meniscus tear at this point. We're to the point now where he's considering orthobiologics or surgery. And so this is probably a little bit below most of the attendees here, but we just want to briefly say what PRP is and then why these definitions may not hold weight anymore. From a definition standpoint, PRP is an autologous blood product with a platelet count above baseline levels. Now, the FDA defines that as a platelet level above 250,000 microliters. I mean, that's not platelet rich to me. That's almost just a normal platelet count. That's whole blood. So we now kind of expect that a platelet level should be 5 to 10 times the basal level for all PRP. And these concentrations are pretty easy to manipulate just based on the volume that you use. You can have a 50 times concentration if you concentrate it down to 1 cc, and you can have a 5 times if you're doing a higher volume. So really what matters is the dose. And what is that dose? What are we aiming for? Well, in 2021, Bonsall showed that 10 billion platelets provided a clinical improvement over lower doses. And then a systematic review by Berrigan in 2024 tried to sort out, where those thresholds are. And when he looked at randomized control trials, I believe there were 32 of them, they concluded that the mean platelet dose in 28 randomized controlled trials with a positive outcome was 5.5 billion, whereas 3 RCTs with no positive difference had a mean platelet dose of 2.3 billion. So, since that study came out, we've all been, trying basically to have a minimum threshold of around 5 billion platelets. And there have been subsequent studies that show that, higher doses may be even more beneficial. So how do we get that dose? Let's do a little math. I don't expect you all to follow this, but if you screenshot it and look at it later, it might make some more sense. So a normal platelet count is anywhere from 150 to 450,000 platelets per microliter. And with an average platelet yield, depending on what device you get, the literature says most devices average around a 70% yield. Well, if you put those two things together and you take a 10 ml blood draw your max dose you're going to get is about 3 billion platelets, and you might get as low as 1 billion. If you triple that and you go up to 30 mLs, max dose with a 450,000 platelet count starting is still under 10 billion. So the only way you're going to get to that 10 billion dose is if you're using a 60 ml and you have, a higher than average platelet count, over 300,000. And I don't know about you guys, but in our clinic, we tend to see more people running 150 to 300 than above 300,000. So my advice, if you don't have a platelet counter in your clinic, we're doing it pre and post for all of our patients, then you should be using at least a system that you can draw 120 cc's. A review this year by Corsini recommended a minimum dose of 4 billion, but an optimal dose of 10 billion for knee osteoarthritis. And they also reviewed studies showed a similar pattern for tendinopathies, showing better outcomes with rotator cuffs and tennis elbows and other chronic tendinopathies if over 6 billion platelets, or if 6 billion was the threshold. So there was also some preliminary data suggesting that peripheral blood mononuclear cells may enhance efficacy. And this kind of leads us to, what else can we do to improve our PRP outcomes? So recently, monocytes have been something that has come up. Now, the problem with isolating monocytes is that we need to, at the same time, minimize neutrophils. These two things are working against each other, whereas monocytes may increase reparative properties and assist in immune modulation, as Dr. Stevens mentioned, and increase tissue regeneration. Neutrophils will do the opposite. They're inflammatory, catabolic, releasing cytokines and enzymes detrimental to healing. Now, this is theoretical and lab-based, and there are very few, if I don't know of any actual clinical randomized control trials looking at OA and tendinopathy in regards to monocyte-rich PRP. So those studies still need to be done. And in terms of alpha-2 macroglobulin, one of our viewers will recognize this image. It's from his paper. A2M is a serum protease inhibitor that suppresses proteinases involved in osteoarthritis. So there have been in vitro studies showing A2M blocking these pathways and leading to reduced inflammation. We just don't have the clinical studies showing that this then results in a better outcome for a leukocyte or PRP product compared to a non-monocyte rich leukocyte poor PRP. So clinical trials are still necessary. So here's our patient, and I'm just going to kind of scroll through this video a little bit. This is patient number 1 with knee osteoarthritis. And first thing I'm doing, and again, feel free to ask questions, leave them in the chat box. This is not the only way to do PRP. This is just how we do it. First thing we've done is sterilize his knee. So you can see the ChloraPrep color, and this is sterile gel on his knee. I like to use a supralateral approach. Some people out there are injecting directly into meniscus. I haven't found a need to do that, especially in a degenerative kind of complex meniscal tear. I don't need to get it into one spot. I just need to get it into the whole joint. So we've already consented this patient. It's obvious he has an effusion in his suprapatellar recess. This is in long axis with the quad tendon over the top, patella on the right. Suprapatellar recess is the large anechoic space in between the two fat pads. Now, since I know I'm going to be causing more of an effusion over the next 3 days with this PRP, I want to get whatever extra fluid is in there out. So the first thing I'm going to do is just anesthetize him and put most of the anesthetic into the soft tissues. Now, there's some debate about how much should we be anesthetizing with PRP or not. Well, since I'm going to be moving through here with an 18-gauge needle to draw off that fluid, I'm going to anesthetize him. And I'm not going to put too much into that space. I'm going to put about 2 cc's total into the joint space and then pull back. and mostly anesthetize the soft tissues. There are studies that show as long as you keep a low ratio of an anesthetic to PRP, you're doing no harm and not going to change any clinical outcomes, even though there are in vitro studies showing that anesthetic does inhibit platelet activation. So try not to flood the area with excess, and I don't use 2% lidocaine or Marcaine or bupivacaine, anything extra chondrotoxic like that. So next, we're going to put the 18 gauge in, draw off that fluid. And finally, we're going to inject our PRP product. So this looks a little more red, and it's than some of our true leukocyte poor. We get a little more red blood cells when we take that layer of monocytes, and I think someone else might be talking about that later. But there's 8 cc's in that syringe, so 4 of those cc's are the PRP, and another 4 cc's in a 1-to-1 ratio are the concentrated platelet poor plasma that we put through the A2M filter. And that won't, if you guys try to inject that through a 25 gauge, it's not going to go, it's too thick. So I'm usually using at least a 22 gauge at minimum, sometimes 20 to inject that. So from this view, the suprapatellar recess is here. This is now in short axis on the knee, so quad tendon is above in short axis. I always recommend, switching between short and long to confirm your placements. Now you can see needle here, fluids being injected and spreading proximally and distally in the suprapatellar recess. And then we're cleaning off his knee, applying a Band-Aid. And, from a post-op protocol, my main restriction is telling patients, no hot tubs, no pools, no bathtubs, no infection risks until, 48 hours is over and that poke hole is closed. From an activity standpoint, I'm not as restrictive as some people. I know some people want to offload that knee for a period of time or avoid activity. I let people kind of ramp up their activity as tolerated, as long as it doesn't include running, jumping, or deep heavy squats in the first 2 weeks. But getting on a stationary bike, walking as long as they want, fine for me. And then the next thing I do is, I'll go over the results of the PRP analysis. So that's what I'm doing with him here. We're going over just how many platelets were obtained in those 4 cc's of PRP, and also then discussing with him why we're using a monocyte rich technique in this procedure. And I think the take-home points for the knee are, the dose matters. So you should either measure it or use at least a system where you're getting 120 mLs. And then from a future standpoint, consider these systems that can allow you to either, obtain A2M and protein-rich PRP or monocyte-rich systems. And we'll see how they play out, as we get more clinical data. Next, we'll talk about Achilles tendinopathy. And this is a talk I gave about two years ago now. I think it was 90 minutes, and we talked about Achilles tendinopathy and everything you can do for it. So, I'm going to talk to you now for 10 minutes, and it's going to be really, really pared down. So if you want to see a longer talk, you can join IOF and go take a look at that. But we're really going to focus in here on just PRP for Achilles. And if you look at the title of this talk, I called it the Achilles heel of orthobiologics, because as you'll see, the data really doesn't support, historical data doesn't support using PRP or any biologic in the US for Achilles tendinopathy. And we'll talk about then why we still tried it for this patient. So here's your treatment spectrum of options for patients with Achilles tendinopathy. This is not specific to insertional or mid-substance. This can pertain to both. And our patient has, like I said, tried everything on the conservative side. And then in the alternative side, I can't remember if he tried steroid. I would never recommend steroid around an Achilles tendon. But he has had an ultrasonic tenotomy and Haglund debridement, which gave him about 60% relief. And he's trying to see if we can get him closer to 90. So here are the most recent systematic reviews and meta-analyses on PRP for Achilles tendinopathy. Now you can notice a few things. None of these are for insertional tendinopathy, and none of them show a benefit. A lot of these cite the same randomized control trials, and you'll see a few of them come up frequently, especially in the more recent ones. In the more recent ones, the RCTs that get cited frequently are Kearney's study from JAMA in 2021 and Thurman's study in 2023. Now, the problem with systematic reviews is if you don't have good RCTs, you're not going to get a good systematic review. And not that these are, were poorly done. I think they just did things that we wouldn't do in the orthobiologic sphere. So if we look at Kearney's study, for one, they didn't use ultrasound guidance. And we'll talk about why not using ultrasound guidance, and who knows where that PRP is going and what kind of tendinopathy they're actually dealing with, because not all tendinopathy is the same. Number two, they injected 5 mLs of 2% lidocaine. Now, when I'm injecting in and around a tendon, I might be injecting 2 mLs of 1% lidocaine. So they're injecting 5 times as much lidocaine in there. And their blood draw was only 9 mLs of whole blood, which is very low. If we go back to our, what can you get from a 10 cc blood draw, you're going to get somewhere between 1 and 3 billion platelets. And so you're taking a low dose PRP injection, you're flooding it with 2% lidocaine, and you're injecting it without ultrasound guidance. I wouldn't expect that to outperform a sham injection. And now we have an N of 240 in those systematic reviews and meta-analyses. And that's going to probably, that will definitely skew the conclusions of those meta-analyses. Thurman's study also showed no difference. But again, they only used a 10 ml blood draw. So I think we need to have better RCTs and we need to have better systematic reviews. So why, treat this patient with PRP? Well, Corsini's study did touch on that there have been similar patterns seen for tendinopathies, that if you use a higher dose of 6 billion, you can get better results. And maybe, using mononuclear cells, monocytes, A2M, maybe we can get a better result. I will say that, and this, I forgot to mention this with the knee osteoarthritis. When I moved to Boston, joined Boston Sports and Biologics, and went from University of Washington to here, I had never used A2M, and I didn't really, there's no clinical studies, so I wasn't jumping to do that. But we use a system called Data Biologics to track all our outcomes. And, just looking at when I was using A2M and when Walter was using it, I could see that, comparing our regular PRP to our A2M PRP, patients were getting better about 20% faster, kind of at all time points. So they were just, they were reaching a similar endpoint at 6 months, but they were getting there faster in the A2M group. So I started using it, and I haven't really stopped for about the last year and a half. And this is what I meant by not all tendinopathy is the same. These are very different things that require different treatments. This partial tear in the upper left, there's a problem with that, is that when you inject it, a lot of that PRP is going to spill out into the Kager's fat pad just because of the deeper surface fiber tear. The diffuse tendinopathy in the middle, and that's probably better treated with maybe 10x, maybe PRP might help too, but it's just a thickened tendon. On the bottom left, we do see some intrasubstance tearing there. That's probably, in my opinion, the ones that do best with PRP. And then these intrasubstance calcifications and insertional calcifications, those usually we're not injecting with PRP. So I don't know, if you're not looking with ultrasound and you're just sticking the needle in there injecting, I don't know where the PRP is going. So here's our patient. And the first thing I'm doing is I'm just going to scan his insertional tendon. And you can see, and I always tell people, after a Haglund bony debridement with 10x, that this area kind of looks like a debris field. So this used to be a large protruding kind of triangular area that rubbed against the undersurface of this tendon. Now it's angled at about 30 degrees downwards here with this irregular slope. And you'll see probably some intrasubstance calcifications around that from the debridement. But the thing that jumps out first are these partial tears of the undersurface. We'll see other things, and we'll see how that tear kind of spreads into the more central tendon later here, this area of tendinopathy. Now, whenever somebody has a large Haglund's, we're usually recommending to at least try to shave that Haglund's down a bit before we go in there with PRP, because if we fix the tendon but we don't fix the bone, that tendon tear is just going to come right back. So first thing I'm going to do is anesthetize the patient. Now, if I really wanted to avoid using any anesthetic, could do a tibial nerve block plus a sural nerve block, but like I said, I'm not as concerned with a little bit of anesthetic, at least especially when you're using a high dose PRP. The one thing we're noticing here as we're injecting is that this is what happens with the tendinopathic tendon, is that flow pattern spreads very easily, and you can see some intrasubstance tears open up. That shouldn't open up so easily. I'm not pushing hard. I'm just basically tapping with my thumb to try to find spots of little resistance. Now, on the other hand, I did a 19-year-old patellar tendon today, and I have to push really hard just to get that anesthetic to flow into the tendon. It's just very tight without much space. So this is kind of the classic thing you'll see with these older tendinopathic tendons. So once he's anesthetized, we'll get our PRP A2M product, and you can see this is only 4 cc's. Again, mixed at a 1-to-1 ratio, so 2 cc's of PRP and 2 cc's of the A2M. I think the whole video will be on YouTube. I'm not sure, but that's up to EmCyte. So again, using sterile gel, we have Tegaderm and a sterile Coban wrap. I like the sterile Coban wrap because it gives me a really good grip on the probe for some of my longer procedures. Now you can see the PRP entering. So I'm not pushing hard. I'm doing this with a really light thumb. And the reason for that is I don't want to distend that tear more than I have to. I want to, move that needle around, let it fill up, and see how much I can get in. Now, probably only going to get a cc or two into that tear, and then have to redirect my needle and go find those other small intrasubstance tears we were seeing with the anesthetic. And so you'll see me pull back here and then redirect shortly, more superficially. And this is probably the initial kind of intrasubstance tear that we saw with the anesthetic. So once all that's in there, the post-op protocol for Achilles tendons and other tendons in general is more guarded, more conservative than with joints, at least in my clinic. Again, same infection risk, so no submerging the ankle. Showering's okay. From a pain management perspective, we use Tylenol plus Journavx, which is a new medication that was FDA approved last January. If you guys haven't heard of it, look it up. I think it's a great option for orthobiologics. And the reason for that is it's not an NSAID. It's also not an opiate. So you can use it and patients can work on it while they're taking it. They can drive while they're taking it. It doesn't cross the blood-brain barrier. Because I don't want my patients on NSAIDs for 2 weeks after or 2 weeks before this procedure. They go in a tall walking boot for a week and then wean out after a week and hopefully are starting their PT by 2 weeks. Gradually going from, as you all know, isometric, concentric to eccentrics, and then finally plyos. So, for this, I think, we still have to trust the literature a little bit. There's too much literature out there that shows no improvement. And so when I talk to patients about biologics and Achilles, I'd let them know that. But I also let them know I think a lot of those studies were done not ideally, not under the ideal conditions. And I think there's a better way of doing it. And I've seen plenty of patients do really well. So I tell them that and then, let them make the decision. But still, they should be focused on the conservative stuff first. And that means physical therapy. And then hopefully, using A2M and monocyte-rich formulations will lead to better results in the future. We'll see.
All right, thank you so much, Dr. Latzka. So we have a few questions already. I think maybe we can take one right now really quickly.
Sure.
And then so one of our questions is when to use A2M and monocyte rich PRP, like for which conditions and for what patients, that sort of thing.
Yeah, I think the one of the things is that if you're using A2M, it's going to cost a little bit more. You're going to have to pay for the filter, so you're going to have to factor that into your discussion with the patient. But for me, I this is just kind of how we've done it in our clinic. We used to see our younger patients doing better with PRP than our older patients, and so in my older patients, I'm using A2M and I'm pretty much just recommending it to all of them because it kind of has narrowed that gap and we've seen them kind of catch up to the younger patients a little bit. Uh, the younger patients, they do well without it. So I'm not, making that recommendation or if they want to do it, fine. But I usually tell them, if you've got mild arthritis or a small partial meniscus tear or mild tendinopathy, small intrasubstance rotator cuff tear, is going to do pretty well. You're young. But in my older patients, I'm definitely recommending A2M. Larger tendon tears, I'm definitely recommending A2M. Not high grade tears. I mean, a high grade tear still might require a little more of a substance, either an MFAT or BMAC or surgery. But for that's kind of how I think about it. And I don't think you have, in terms of monocyte riches, if you have access to the EmCyte new kit, you could do that for all of your. That doesn't add any cost. You just have to know how to do it. So I think why get those neutrophils? I don't want them in the product anymore, and I still want to get these high dose PRP counts. So I'm pretty much going to use that for all of my. I think unless there's a study showing me that it's doing some harm, which I can't imagine, that's just going to be probably my new standard protocol.
Okay.
The
Thank
A2M is
you.
more optional thing.
Got it. Thank you. So we're gonna hop over to Sina for the scientific perspective. In the interest of time, sorry, Sina, I think you don't need much of an introduction, but so Sina is our resident expert in tissue engineering and regenerative medicine, and he has designed and developed a whole array of innovative, smart biomaterials. I won't get into all of them, but they're very, very impressive. And without delaying much further, Sina, we'll hop right into your presentation.
Thank you so much, Natalie. So can you see my presentation, everybody?
Yes.
Okay, perfect. So I'm going to skip some of the introduction as Natalie mentioned. Thank you, Dr. Latzka, for great clinical perspective. So I'm going to talk a little about the basic science and the mechanism of action for the monocyte-rich PRP in combination with the concentrated protein. So up to today, most of our conversation is around the PRP have been cell-centric. We focus on the cellular fraction of the blood, including platelet, different leukocyte, and in some by formulation, even a small flash of the red blood cells. But PRP is essentially, by its name, platelet-centered biologic. Once those platelets are activated and degranulated, they release a cocktail of the cytokine and chemokines and growth factor, things like PDGF, IGF, VEGF, EGF, and interleukins. But depending on how we formulate the PRP based on the inclusion or exclusion of the leukocyte, different types of the leukocyte, we can get the regenerative, reparative function of the PRP or anti-inflammatory function of the PRP. However, in our blood, beyond of the cellular fraction, we have actually protein fractures and also small molecules. And with the current system, current setup of the centrifuge-based preparation method, we cannot isolate the protein and small molecules. Actually, if we want to get the protein and small molecules, our RPM set up for the PRP for the centrifuge should be over 20,000 RPM and with very high G-force. And with that G-force, actually we damage the cellular part of the blood. So actually, when we prepare the PRP, specifically in the double spin system, after the second spin, we are going to have platelet poor plasma, which is enriched with the small molecules, protein, and we only take a portion of that for suspending our Buffy code, and we actually discard the rest of the platelet poor plasma or PPP, which is which is enriched with the platelet, with the protein and small molecules. However, we need to consider that we need to know about the component in the PPP. In the reality, that PPP is about 90%, 91% water, 7 to 8% protein, and the rest is the other soluble molecules. Actually, 22 most abundant protein in our plasma represents approximately 99% of our total protein mass in our body and can be categorized under one of these categories as functional plasma protein, tissue leakage protein, which usually indicates the disease state, and also signaling proteins can be hormones, growth factors. And so we usually don't consider them because we cannot isolate them just with centrifugation. However, with the new technologies as ultrafiltration system, now we are able to actually recover the protein part and add the protein fractions to the PRP by formulation. As you can see, this is the EmCyte core filter system, and we can already use this system to wash out the platelet pore plasma, which contains 90% water. And based on the pore size of this filter, we could remove the protein with the size smaller than 20 kilodaltons, which is mostly contain the inflammatory cytokines, and retain everything bigger than 20 kilodalton in a size. So as you can see, when we attach the syringe contains the platelet pore plasma, first we need prime the filter and then attach another syringe. So the important important trick in this system is applying a vac lock syringe and apply the negative pressure to make the process easier and faster. And you can see when you apply the negative pressure, eventually it's going to be very smooth for you to back and forth, and eventually your volume could be decreased and the water goes through the vac lock syringe, and you're going to have the concentrated plasma, which is enriched with the essential protein, and we're going to talk about later in our next slide. Okay, so when you have this concentrated plasma, you could use and return it back to the PRP kit and resuspend the PRP buffy coat, which you collected at the bottom of the kit, bottom of the tube, and resuspend the buffy coat with the concentrated plasma instead of the platelet pore plasma. In this way, you are gonna make the protein-rich PRP. And regarding to the bioformulation of your PRP, you actually choose the bioformulation by inclusion or exclusion the leukocyte during the first and second speed. So in the both cases that Dr. Latzka explained, we actually use the protein-rich, monocyte-rich PRP with this system and method. So as I mentioned earlier, we have a bunch of different proteins in our plasma, and I already listed the proteins as our target. Actually, we tested the recovery of them in our lab, and so you can see the concentration of them in our blood plasma is very, very in a good level, and with the concentration 4 times, 5 times, we are going to have even more. The function of these proteins are already mostly anti-inflammatory, anti-protease, or even some of them as the regenerative and reparative as a structural protein, we can use the benefit from them. I already put the 10 targets here, except one of them, which is the TNF-alpha, as inflammatory protein, and I wanted to test how our system can remove the most of the inflammatory protein. Other 9 proteins we actually received, and we actually got very good recovery percentage with the core filter for these proteins. The things you should notice in this table is the size. Except the TNF-alpha, which is below 20 kilodalton, and we expected that to remove the TNF-alpha and most of the inflammatory cytokines, their size is also their size are also below the 20 kilodalton. We have IGF-1 with the size around 7 kilodalton. But in reality, in our body, some of the growth factors, some of the proteins like IGF, they already are bound to other carrying protein, and with this system we can retain them because the actual complex size is going to be over 50-60 kilodalton. Why IGF? Because today IGF is one of the most interesting targets for a longevity field, and actually now we are receiving the data in the basic science preclinical studies that IGF can help mitogenesis of the mitochondria, and it could help for inflammation, subsiding the inflammation, and so on. I didn't actually include the rough data for the recovery because we haven't published them, and very soon you are going to have that publication in the literature. So since the A2M is the key player and the famous one, we are going to go over the mechanism of action for the A2M. It acts as a broad protease inhibitor, trapping the enzymes such as MMPase, matrix metalloproteinase, and preventing the excessive degradation of the extracellular matrix, either collagen in the tendon or the collagen and ECM for the cartilage. So far, most of the conversation around the A2M focus about the anti-protease activity, but A2M also can reactivate and potentiate the growth factors, which they usually have very short bioavailability, because the mechanism to minimize the bioavailability of the proteins and growth factors usually in our body is phosphorylation. A2M can bind to the phosphorylated part and actually inhibits the phosphorylated part function and recover the actual function of the protein or growth factor. For example, for IGF, we have very short half-life, and also it gets phosphorylated, but A2M can help to recover the function of the IGF. Also, A2M has that ability to act like chaperone proteins and helping stabilizing the misfolding proteins and preventing their aggregation, which support a cleaner environment for tissue repair. Actually, in osteoarthritis, mechanical wear and aging push chondrocyte into hypertrophic state where they release cartilage breaking enzyme like MMPase, as I mentioned, and damaging signal like DAMPase. These signals activate synovial cells, which then secrete TNF-alpha, interleukin-1, interleukin-6, and more MMPase, creating chronic inflammatory environment that accelerate the cartilage and bone damage. A2M actually binds these cytokines and protease, trapping MMPase and ADMHTS, and make a cage for them and helping to break matrix breakdown and protect the cartilage surface. As Dr. Latzka mentioned, we don't have that much clinical study regarding to the A2M, and hopefully in next 2 years we could have better data, because now using the collecting data platforms, we are recording the data, we're collecting the data, and the combination of the concentrated protein or A2M with the other modalities like PRP and bone marrow, and hopefully we could get better clinical data. So far, we have a few clinical studies. One of them is actually this study. It started at 2013 and updated in 2024. They actually compared the efficacy of the A2M compared to PRP standalone and corticosteroid for 75 patients. And after 12 weeks of follow-up, they already reported the comparable efficacy of the A2M compared to PRP and corticosteroid for mild to moderate knee osteoarthritis. But we usually use the A2M in combination with the PRP, not a standalone. Another study, actually the intradiscal injection of the A2M to determine the ability of the autologous A2M to relieve the back pain. In this study, 40 patients already were enrolled, and finally, after 6 months follow-up, the data was available for 24 subjects, and the patient outcome shows both pain relief as VAS score and functional score improvement for the intradiscal treatment with the A2M. Another study used the A2M as a novel treatment for patients with chronic pelvic pain syndrome. In this study, 19 patients received approximately 5 ml of the A2M, again, a standalone, for each patient, and pain and function were assessed via VAS score and also functional pelvic pain scale. As you can see, in most of the criteria, we have improvement with the A2M. And the last study I included in this slide, it's a case series report, which described the successful treatment of the A2M for neuroma pain for a 30 years old female patient with amputee. The patient underwent 2 sessions of the A2M treatment 2 weeks apart, and actually patient reported significant pain relief, and ultrasound showed decrease in neovascularization and cross-sectional area for neuroma, and the efficacy of that treatment long lasted for 2 years. Another actually interesting protein we need to consider eventually, because the concentrated plasma is not just A2M, and A2M is not the only player, is the serpin family. Actually, in our body, we have 36 different serpin as a serine protease inhibitors, but the 30 member of this 36 family, actually they are anti-protease, and they are the biggest natural anti-protease community in our body. So as you can see in this cartoon, in our plasma, actually we have the serpin A1 and serpin A3 as the most abundant one among others, and also our chondrocytes can produce that. And one of the marker we could find as the initial step of the osteoarthritis is a little elevated level of the serpin A1 and A3, like A2M, as a natural response of our body to the injury and to the osteoarthritis. Same as the A2M, when we have the inflammatory condition for our joint, for our cartilage, our chondrocyte start to release that, and or if we apply as exogenous concentrated protein, which has the serpin A, serpin A1, A2, A3, and others, they can actually inhibit the activity and inhibit the protease activity, specifically in this case, leukocyte elastase, and inhibit the interleukin-6, TNF-alpha, and other inflammatory mediators. Regarding to the serpin A1, there is only one preclinical solid study. They actually use the serpin A1 as a treatment for both intra-articular injection and also for systemic administration for both mice and rat model, and they saw that serpin A protein can reverse the joint inflammation, nociceptions, and cartilage degradation, and also ex vivo analysis of the arthritic joint revealed that the serpin A1 can downregulate MMPA13 and ADAMATS5 gene expression. As I mentioned on that table, and I showed you, we have other proteins, not just the anti-inflammatory and anti-protease protein. We actually have a structural protein like fibrinogen and fibronectin. The most benefit we can get from the high concentration of the fibrinogen after activation of the platelet coagulation cascade, changing the prothrombin to thrombin, and cleavage of the fibrinogen toward the fibrin, we are going to have a kind of mesh and a 3D matrix that helps to have the sustained release of the growth factor and a kind of a scaffold for soft tissue. So when we use the concentrated protein, which is not just A2M, that a specific protein as fibrinogen here could help in this way for both cartilage in the joint and soft tissue as a tendon. Another protein is going to be the fibronectin. Fibronectin is famous as adhesion molecule, adhesion protein. And studies showed when we use the fibronectin for the cartilage, it helps the progenitor cells to attach and move toward the defect. Also, the same scenario for the tenocytes and tendon progenitor cells to have better organization and regeneration with the fibronectin. Also, when we apply the fibronectin in a joint, we could get the benefit of the lubrication with the fibronectin. Albumin is the most abundant protein in our body, and as it acts as one of the most potent antioxidant. Most of the inflammatory condition, we can see the footprint of the oxidative stress and ROS and NO2. So with the albumin, we actually have a very potent antioxidant, and also we can get the benefit of albumin as a carrying protein, since we have a bunch of growth factors with very short half-life. Having the albumin, it could help them to have longer bioavailability and bioactivity by encapsulating them. And the last protein I'm going to talk about is the ApoA1, which is a protective anti-inflammatory protein for knee osteoarthritis. Actually, one cohort study of 184 patients showed higher ApoA1 level in synovial fluid were linked to less cartilage damage, lower KL grade, and better WOMAC. So it has the same actually mechanism for anti-inflammatory action by reducing the TNF-alpha and interleukin-1 in multiple inflammatory disease, including the osteoarthritis. So we talked about the monocyte reach, and Dr. Latzka mentioned the monocyte reach. We talked about monocyte reach before in our previous webinar. Just to remind, when we have the monocyte, the high concentration of the monocyte alongside with the platelet, actually platelet can give signals to them. And in this case, we are going to have mostly anti-inflammatory monocyte, and monocyte can be differentiated toward mostly anti-inflammatory macrophages. So that's why when we have the PRP as monocyte PRP, since we have the platelet, high concentration of the platelet, with the monocyte, we are going to have more and better immunomodulation properties from the monocyte-rich PRP. And also the rationale to combine the monocyte-rich PRP with the concentrated protein, as we mentioned, different types of the protein, not just A2M. We could get simultaneously anti-protease activity, anti-inflammatory activity that helps the immunomodulation, and also some structural properties of the concentrated protein, like the benefit from the fibrinogen and fibronectin, and also anabolic properties of the IGF-1. For IGF-1, we need probably another session of the webinar, because it's very, very huge information behind of the IGF-1 now. So for tendinopathy and tendon injury, same concept and same rationale. We have with the monocyte reach, we can change the chronic inflammation and irritation toward the better calm situation. And also one thing in soft tissue, we usually need angiogenesis, organized angiogenesis. Before we use the neutrophil reach, but neutrophil is a gas on a fire, and we don't want to use that for chronic inflammation. And also, if we include the neutrophil in our PRP bioformulation, we actually diminish the benefit of the anti-protease and anti-inflammatory of the concentrated protein. So we don't want to combine them. So we prefer combine the monocyte reach with the concentrated protein to get the benefit, and also for soft tissue, get the benefit of the angiogenesis and vasculogenesis. And for the rationale behind the concentrated protein for soft tissue and tendon, similar to the joint, but in this specific tissue with the a structural protein like fibrinogen and fibronectin, we can get the benefit of the scaffolding from them, and we can get better organized collagen 1 synthesis. So thank you so much for your consideration.
That was great. Thank you, Sina, for that deep dive into the mechanism and for going into all those plasma proteins for us. So I had a quick question. So Dr. Latzka talked to us about platelet dosing as critical, and then you just talked to us about the monocytes and their role and their interaction with the platelets. So can you talk to us a little bit about platelet to monocyte ratio, and are monocytes taking over? Like, what's going to factor in more importantly as far as dosing, do you think?
Yeah, even in the PRP, the dosing conversation has been started very, very recently. And before, we mostly talked about the concentration factor, which is not a precise way to define the actual properties of the PRP. We have the same condition with the monocyte. Actually, we try to get the benefit of the leukocyte specifically, not just as one umbrella for the leukocyte. We are going to divide them as a leukocyte, monocyte, neutrophil, or lymphocyte. There is no evidence in the literature how much monocyte is enough, how much monocyte we need to have in our PRP system. And still, we don't have any standard scale for calling the bioformulation as monocyte rich or neutrophil rich or leukocyte poor or rich based on the percentage of each of them. So there is only one study actually showed not in the PRP system, just polymononuclear cells as a standalone modality, and they showed if we deliver between 70 to 120 million polymononuclear cells. It could be monocyte, lymphocyte, and dendritic cell. We could get significantly better outcome for knee osteoarthritis in 4 ml biologics. But rather than that, we don't have any data, and we need eventually start designing the studies to compare the different deliverable, because we have in our body a range, and it's very wide, 2% to 8% monocyte.
Absolutely. So let's look into our chat for questions from our participants. So Dr. Latzka, I think this is for you. For tendinopathy, is it better to do an iron tendon injection or peritendon injection?
I would just definitely say intratendinous, especially for an intrasubstance tear. Now, if you have a bursal-sided tear, probably doesn't matter. You inject it right into the tendon; it's going to flow right out into the bursa. If you have a articular-sided tear, also probably doesn't matter. It's going to flow out into the joint. So, but if you don't know what you have and you're just injecting peritendinously, you could be missing an intrasubstance pathology. So if you're not sure, I would say you could do both, but the intratendinous will get you there no matter what. And one thing I wanted to touch on that you said, Sina, you did show a better way of doing the A2M and then resuspending the PRP in it. So it's basically like 100% A2M resuspended with the PRP, whereas I did a ratio. The reason I do the ratio is not for better outcomes, it's just for better data tracking. If we do 100% A2M, we can't analyze it in our counter. It's too thick and it'll cause an error. So we've realized realized if we do 1-to-1 ratio, we can still put a drop of that and count the platelets. But we'd have to come up with a different way of counting our platelets if we were going to do 100% A2M, or we'd have to get a different counter if you have a counter that works for that.
Thank you. And then, so we're running out of time, but we'll take one more question, and it's a request for a quick recap on how to select PRP versus PRP with A2M, or PRP with monocytes or without A2M. I don't know if that can be a quick one, but as best as you can.
Look, we kind of already did that one. I thought that was similar to the first
Oh,
question. We had.
did I miss that? Let's see. Could you talk about wow. Okay.
So
I'm
Maybe Sina wants
sorry,
to take
if I
that.
just mention a point in 20 seconds regarding to the combination of the PRP with A2M and counting the cells. I agree 100% with Dr. Latzka, but a new cell counter is coming from the EmCyte, and we can offer that even for that rich, concentrated combination and biologics. We can count the cellular part very well, very precisely. And also one question regarding how we could actually select PRP for different condition or PRP with the A2M. The only things I would like to notice, when you combine the A2M with the PRP, don't use the neutrophil-rich PRP. As long as you don't use the neutrophil-rich PRP in the combination, you are going to be on the safe side. We can get the benefit of neutrophil-rich for some specific indications, but if you want to combine with the A2M, don't use the neutrophil-rich.
Okay. All right. So we do have a few more questions, but we've gone over time, unfortunately. I'm sorry we couldn't address everything this evening, but I just wanted to jump to the upcoming announcements I mentioned earlier. So we have a precision in medicine. EmCyte has a precision in medicine. Let me see if I can just share my screen quickly. We have a precision in medicine conference coming up on May 1st to 2nd. And it's going to focus on MSK ultrasound and bone marrow aspiration. We'll have Dr. Michael Meng, Dr. Randy Miller. For adipose harvesting, Dr. Michael Meng will focus on spine injections, Dr. Rowan Paul for nerve hydrodissection, and Dr. Irizarry Roman for bone marrow aspiration. So that's coming up. So please go to the Gulf Coast Biologics website to register. We also have ultrasound guided training by Leslie Asia, and that's on site at Gulf Coast Biologics in Fort Myers, and it's free ultrasound training. Let me mention that again, it's free, so please take advantage of that. Also go on the Gulf Coast Biologics website and register for that as well. And then finally, EmCyte has a new app. It's called the EmCyte Power Sales app. And you can use that for ordering. You can download it on your phone, use it for ordering. It also has a tool for doing calculations for platelet recoveries and things like that. So it will make life very easy for you. So we'll end right there. And I just want to thank everyone for being here, for participating. We've covered a lot this evening, and the conversation could have kept going. Unfortunately, we're out of time, but take homes here are dosing is key, precision ultrasound guidance is key. We want to use that monocyte rich PRP with A2M. That combined approach, as Dr. Latzka mentioned, does make a difference as far as timing with patient outcomes. And we appreciate your time and your questions. It's clinicians like you guys and your contributions that's going to continue to shape the landscape of orthobiologic medicine. And we really appreciate your participation and being here this evening. So hopefully we'll see you at the next webinar, which is coming up in a month. Check out the GCB website for more information. And once again, thanks for being here. Have a good evening.
Thank you for joining us in this session of EmCyte's webinar series. Stay tuned for our next episode as we continue uncovering the science behind precision biologics.